Okay, this module deals primarily with the medications used to treat um, abnormal behaviors, primarily the medical ones. There is some comparison to a couple things here. Um, Unconsciousness, when we talked about different types of drugs, and then also from the biology unit, we'll talk a little bit more about things like neurotransmitters and some of those specific names. For those of you taking the AP test, it's kind of a good review over that too, because we're going to talk about some of those same terms. Okay, so when we look at drug therapies, it's kind of one of those really debated topics because many people feel like that uh, sometimes these biomedical therapies really seem to cause more than they cause more issues than they actually are helping with abnormal behaviors. One of the things that you should know is psychopharmacology. That's basically what psychologists that are studying the effects that drugs have on mind, but also behavior. Things that we have to look for in um, drug therapy is um, looking at the normal recovery rate of untreated patients. So, you know, you don't, in this case, they don't want to do overkill where they have, caused more issues than they've actually helped. So, if it's something small that could possibly be met with something else besides medication, that tends to be uh, something that can be um, a factor when considering drug therapies from the therapist's perspective. There's also the placebo effect. When looking at the placebo, many times um, it really people you give them some type of medication. Many times they begin feeling better, not because the drug really did anything, just because it was in their mind. Basically, it's the placebo effect. You guys all know what that is. There's also, in order to downsize the effect of the placebo, they've done double-blind procedures. So when the staff or the patients um, have been given medications and they did not know which would be a placebo and which would be the actual drug, there have been studies that show the drugs are actually working, which is good, at least from those looking to improve from abnormal behaviors. All right, so let's look at some of these drugs, and I'm probably not going to say these right, especially right now, but that's okay. If you want more um, help on those, you can refer to Joe or Mallory. I'm sure they would do great with that. So, the antipsychotic drugs are used to treat schizophrenia. Other types of severe thoughts disorders. One thing that's actually a part of some of these is many times they're used in um, epilepsy treatment also. So it's not just schizophrenia. Some of these same drugs, you'll see the terms of them um, also used in other medical procedures, not just abnormal behaviors. Um, so when we look at these anti-psychotic drugs, what we're looking at um, is the purpose of them is to to decrease the amount of psychosis, which is the hallucination or delusions, especially in those with schizophrenia. Um, I think DID also would play a part in the antipsychotic drugs. Um, so when they're having those extreme hallucinations or delusions, they're trying to minimize that effect. Now, chlorpromazine, also known as thorazine, not saying, I'm sure I'm saying that right. They both, well, it's kind of there's two terms there. They dampen the responsiveness to irrelevant stimuli. Now, the purpose behind this would basically to be able to slow the responsiveness down. So, some of the things that possibly someone with OCD might find this. The compulsions of going through the same things over and over, some of the irrelevant things or the irrelevant stimuli, when they have that thorazine, whatever, that can tend to reduce the responsiveness to the stimuli. Now, if we look at dopamine, from what we know prior to that, is that uh, okay. Hopefully, we're past the crisis. All right, so we look at dopamine. It's an overactive dopamine in the system, especially looking at schizophrenia. So these antipsychotic drugs are antagonists. If you remember from biology, that antagonist is going to go to those receptor sites, and it's going to be like the neurotransmitters. It mimics it. Um, we also have a side effect of antipsychotics, and those actually look somewhat like Parkinson's disease. It's called tardive dyskinesia. It's when their facial muscles move involuntarily, and this is after being on. Especially if you look at some of these drugs that people have been on for a very long time, you'll start to see that side effects, which is something that many times psychiatrists will really try to reduce that because I mean, for sure you want to try to give them a normal life as possible, not giving them Parkinson-like symptoms. There's also other ones. I'll let you say them out loud in class. Here you go, Joe. The R1's yours. Mallory, you can say the O one. Both of those increase the risk of obesity and diabetes, which some people argue should not be given or should have reduced doses because they're causing other issues that could also be fatal. We have anti-anxiety drugs. They're used to control anxiety and agitation. So people that deal with anxiety sometimes are on these. These anti-anxiety drugs are like Xanax, Ativan, and D-Silercin. One of the things that they really have an issue with these, this has been probably the most major of drug therapies, is that there is a uh, physiological dependence on these. Now, that problem right there, it tends to, people tend to go into withdrawal once they stop taking it. Um, Also seems like over time they can't seem to get off of it. So they've tried to prescribe them in lesser amounts or try to change it enough so that there's not a physiological dependence on the anti anxiety drug. Antidepressants. It's used to treat depression, also anxiety disorders, both of them, um, OCD and PTSD. Um, it's mostly mood disorders, anxiety disorders that use the antidepressant drugs. Probably the most famous one and probably the most teased about one is Prozac. Prozac is what most people know as an antidepressant. Um, One of the things that it does is it does selective serotonin reuptake inhibitors. Now, think back to that neuron that we talked about at the very beginning of the year. How when the electronic wave comes down the axon and those neurotransmitters are dispersed, there's that reuptake that takes back to the neuron the leftover neurotransmitters. And when there's this is inhibiting the serotonin in that. One of the other things that it does seem to have an effect on is neurogenesis, which this is the birth of new brain cells. Um, One of the things that uh, this idea of neurogenesis, that it's on a very small scale. We can't look at it as a broad thing like you're creating new um, all of these new brain cells. Well, really, what it is as stress and other things have decreased brain cells, this possibly would be replacing them. One of the side effects of antidepressants is dry mouth, weight gain, and hypertension, which brings a lot of critics to say that, some of these things like weight gain, hypertension, possibly have fatal or problematic effects greater than the depression itself. It's a catch-22, really, on that point. We look at the antidepressant drugs. Here we have my mouse. There we go. The sending neuron. Here's our action potential. We have our synaptic gap. We have the receiving neuron. And many times, this is serotonin molecule. There's the receptors where the serotonin will go to. But what we find is some of these neurons that are serotonin, they're reabsorbed by the sender neuron. It's the reuptake. But we look at Prozac, it actually blocks the reuptake. It's uh, like a block on a dam that stops the flow of water. It basically puts the Prozac goes into that receptor site. It is the antagonist in that case, and then that excess serotonin in that synaptic gap gives it its mood lifting effect, which could also cause physiological dependence. Also, mood stabilizing medications. Um, this goes actually a little bit back to on the mood stabilizing goes a little bit back to seizures also. We have lithium, which it reduces uh, bipolar for sure. It's really important for bipolar patients, especially with the mania. We also have Depakote. Now, Depakote is something that also has a lot of effects, side effects also. Uh, One of the things with Depakote is it really helps with the mania side of the bipolar. Really gives that help there, especially on the mania, one that's experiencing the high mania. Now, if we look at brain stimulation, this is something that has been used as a therapy also, but it's more medical than it is like a group. Let's sit around and talk about this therapy. We have the electroconvulsive therapy. This is what we take. It has to be a severely depressed patient. They need to be. It's not someone you just go to the psychiatrist one day and they give you electric shock therapy. That's not how that works. It's more like the person has been in a psychiatric ward for a period of time. All other things are not working, and then it is used. This electroconvulsive, it basically sends a brief electric current through the patient. They're normally under anesthesia. It's only 30 to 60 seconds. And this is only with treatment-resistant patients, meaning they've tried drugs, medical drugs, they've tried different types of therapies. None of them are working. One of the things that we find with this is that it seems to uh, one of the things it seems to do is it could encourage a relapse. It is possible. Also, it seems like it might have a placebo effect. Once someone goes through electric shock therapy, it seems like maybe it's more of a mental transfer rather than actually a biological help. It is possible.